Millionaire if I did. So I'm Tasneem Patel. I'm a family medicine doctor by training, but last 10, 12 years I've mostly done functional medicine. So I wanted to do a talk on small intestinal bacterial overgrowth and then realized that maybe everybody doesn't know what functional medicine really is, and so I wanted to take a minute to talk about what that is. So I practice primary care. I'd have patients come in. I've got this problem. I'm dizzy. Okay, like I've seen you for the 8th time. I still don't know why. I've done EKG. I've sent you to cardiology. I've done everything. I don't know why. So I was never satisfied with that. I also went to an osteopathic school where we are learning about root causes and root cause of why something happens. Not just that it happens and here's a medication for it. Here's a medication so that this is your diagnosis. It's like, why do you have this happening to you now, and how are we going to investigate and find out? And so a lot of osteopathic principles came that way. Also growing up in a house where my mom's like, halad nu dudh pilo, like, okay, I got it. Everything is like, there's a natural thing to do for something going on. So about 10, 12 years ago when I was working at Kaiser, I did a lot of like hormone health for women. And I got very interested in doing functional medicine, and so since for probably maybe the last 11, 12 years, that's what I've done. So when I do primary care, I focus on why something is happening and look a little bit more in depth in general. So I want to kind of introduce that a little bit more too, and then do it in light of SIBO. I also, unfortunately, do not have any financial disclosures, which is sad, but there you go. So learning, we're going to talk about what functional medicine is, and then I'm going to tell you about what SIBO is, so you can understand how to diagnose and how to utilize this in your practice. Definitely takes more time. There are barriers, definitely, because a lot of gut health, which is what SIBO is going to be, relies on diet, and diet is different depending on different cultures. Some people have more carbohydrate intake, some eat different foods, so it can definitely play a part. So again, what is functional medicine? It's a holistic approach to looking at the patient as a whole, to look at every aspect of their life, not just like what they came in for. Unfortunately, that requires a lot more time than is allocated. So if I was working at a primary care clinic, I had 15, 20 minutes. In that time, my MA has to get the person in, I have to see them, I have to like chart. It's not possible. So my appointments are definitely longer in doing this, but I'm looking for root causes. I'm looking for, is the form correct? Do they have everything that they need? And then is it functioning well? Because just because they look okay, just because they seem okay on tests, doesn't mean they're functioning well. So a lot of times normal tests are not optimal tests. So let's just take this as a quick example of how I would go through this. 62-year-old male, BMI 28, healthy, comes in with a blood pressure that's slightly elevated in the last 3 months, not on anything, some headaches, fatigue, maybe just due to work and being 62. So if you came into a conventional medicine, like if you came into a primary care, you'd be like, okay, let me get your history, find out what you're about, do you smoke, drugs, what's your family history like, probably order some labs if I thought about anything, if I heard anything on my exam, I might do an EKG, get an echo, and probably start with saying, eat less salt, exercise every day, monitor your blood pressure, and let's see what's going on. And then if it seemed like it was continuing, probably give a blood pressure medication. That's kind of really pretty standard, quick, okay, kind of manage blood pressure. But if I'm doing it from a functional medicine approach, I'm going to do a lot of the same things. But in my history, I'm actually going to dwell a little bit more into like sleep and movement and nutrition and stress and relationships and mental and emotional health, because all of these things play a huge part. We see it time and time again. When I used to work at a county clinic, I remember this was like when I was still doing my residency, and there was like a ton of women who came in, Russian women who came in with heart pain, chest pain. And it was interesting because none of these women really had any cardiac stuff, but it was just chest pain that they came in with. And I realized after I was talking to my attending at that time that it's very common in Russia for women who have chest pain to go to the hospital and then get like almost like a 10-day resort kind of feeling where they're like away from stress at home and that work life, because they're just so busy working that having the chest pain and being in the hospital was much better. So it's just very interesting, the cultural things and what happens. Sleep, I can't tell you how important sleep is. We compromise sleep. We tell our kids to sleep on time, but as adults, we compromise sleep. And now more so than ever, because we're on our phones doing something. I'm guilty of it too, like mindless. I'm like, why am I spending this much time? But sleep is important. Nutrition, stress, that's like pervasive into everything. So if you can't manage a lot of these things, you can't really change it. So the direction in which you go, the history takes a little bit more time. Ordering labs. I'm going to order similar labs, but I'm also going to go in a little bit more. When I do a thyroid, I do a more extensive panel. I look for ferritin. If I do a cardiac blood workup, I'm looking for oxidized LDL, LP(a). I'm looking at particle size. I'm looking at the quality of the HDL, and not just that they have HDL, because HDL alone is not necessarily the answer. I may even check their adrenal glands if I'm thinking stress, sex hormones if there's any kind of any hormonal issue that I'm worried about with periods, whatnot. Heavy metal toxicity, where did they grow up? What did they do for a job? Gut evaluation. Gut evaluation is huge in functional medicine. It is like the core of who you are. If your gut doesn't work, you don't work. Messes up your hormones, messes up your detox. There's connections with autism and ADHD and all these like anxiety with gut health. So getting gut health down is one of the cores of functional medicine. And I want to say like functional medicine, it's interesting because it's like I think like people think like, oh, this is a new fad, this is a new trend, this is like what everybody's talking about. But this is a concept that is just marketed better now, but it's been around for a long time. That's what osteopathic principles are, and they've been around since the 1800s, looking for that cause. I'll still do imaging if I need to, or not imaging, but like any kind of workup like EKG, whatnot. I'll still tell them to eat less salt, exercise, hydration improvement, sleep improvement. Where are we going to do that? Pain management. Pain's not controlled well. It's very difficult for people to function. And then my first line of managing something like the hypertension would be supplements. I look to go for supplements first because if I can do it that way, I have less calls about side effects like, oh, I have a cough or I have fatigue or I have, depression with my hypertensive meds. So I do that, but I'm not to say that I wouldn't give prescription medications if need be. So I'm going to shift gears now with that whole background on functional medicine. One of the things I see is this particular condition called SIBO. And Calvin complains abdominal bloating, belching, burping, cramps, diarrhea, and sometimes those are very, very common, like for abdominal stuff, things you would think for the abdomen. But then you start getting into stuff that's like, well, I'm always tired, I'm just always in pain, I just have joint pain. And these are not specific to the gut, so you don't really think gut. I need to evaluate this. But a lot of these symptoms can be very common in SIBO. And so what is SIBO? SIBO is small intestinal bacterial overgrowth. It's overgrowth of normal bacteria that should be in your large intestine, but that has somehow found its way back up, and it is now in your small intestine. So it's the wrong location, but still good bacteria. The bacteria generally involved are Klebsiella, E. coli, Enterobacter, and Strep. Sometimes you can have yeast or lipopolysaccharides there as well that can cause these symptoms. So what does this bacteria do? It destroys your microvilli. It makes them more leaky, so now you get leaky gut. Once you have leaky gut, things you can, when you eat things, they start to leak over, so to speak, into your bloodstream, and they create an immune response. Thus, autoimmune conditions are kind of more on the rise right now, as we see. So we want to check for a lot of these things. And then they slow down your gut motility. So instead of having a bowel movement once or twice or even 3 times a day, you're having one bowel movement every 3rd day, which is not ideal. How did this happen? SIBO doesn't just happen. The bacteria has to get in and it has to stay in. And so what keeps bacteria in and keeps it from getting killed? Well, there's many reasons. These are just some of them, but not having enough digestive enzymes, low stomach acid, so you're not breaking down the bacteria well, low motility, things are just sitting around, so they're fermenting rather than pushing through, stress, aging, medications that affect pH of the stomach, and narcotics, which kind of slow down the bowels. What does the bacteria do? Again, we talked about it getting into your intestines, particularly sugars, and it starts to ferment and it starts to produce gas. The invasive strains the bacteria can produce enzymes or endotoxins which further damage the epithelial cell layer, and the two gases that are produced are methane and hydrogen gas, which cause a burping, bloating, belching sensation in most people. The testing, how do you test for this? The gold standard is to do a GI aspirate, but not very easy to get, and so for someone like me, I usually resort to the breath test, and the breath test is a lactulose, and it's a 2 to 3 hour test. So the way the test works, and this is the perfect time, so if any of you are feeling bloated, belchy, burpy, we should consider this because it's usually a few hours later. When you eat something, the transit time between eating it and getting into your large intestine is anywhere from 2 to 3 hours. So during that time, if you've got bacteria there, it's going to produce gas if it's given the food. The food so the way the test works is you get a series of tubes and you breathe into a tube, without doing anything. So first just breathe in. Then you take a lactulose solution. Lactulose kind of lasts through your gut without getting digested like glucose would sooner in your gut. So that's why they use lactulose. And then every 20 minutes, 20-minute increments, you're doing a breath test again to measure gas. So that's what they're going to measure, the methane or the hydrogen gas. The reason there's a 2 and a 3 hour is because some people are like, I eat and I still feel like it's still sitting there for a long time, like it's not getting through. So if they have a slow transit time, the 3 hours will give you more time to see if this is what's going on. So that's why they have a 2 and a 3 hour one. There are other tests that you can kind of get clues from, that this person might have SIBO and maybe I should test them, like nutritional deficiencies, or there's an organic acid test that looks for vitamin levels and how your energy cycle is working, but there's clues on there that can tell you that you might have SIBO as well. So when you get the results back, this is what the results look like. You start with sample 1, which is at time 0, and then every 20 minutes you're measuring it. So you're measuring the methane gas and the hydrogen gas, and you're looking to see if there's a rise at any point. Clearly, if it's a 2 hour thing, it's going to end. If it's a 3 hour thing, it'll go on for 3 more test tubes or collection samples. This is just in a graph form, so you should see this. And it'll tell you if your hydrogen is over a certain number or your methane is over a certain number, or if the combined value is a certain number, that's a positive test. I'm sorry, I'm going fast because I know everybody wants to go through other stuff. So if the hydrogen gas reading is over 20 parts per minute, if the methane is over 10, or if the combined is over 15, that's a positive test. That means you have SIBO. All right, so what do we do with SIBO? SIBO is a bacterial infection in your small intestine. And so the first goal is to kill this bacteria in your gut. And how do we kill bacteria? We use antibiotics. The common one to use is Xifaxan. Xifaxan is a non-absorbed antibiotic. So it doesn't have systemic absorption. It works in the gut. The concentrations stay higher in the gut. So it tends to, it works well. You use it for both hydrogen type and methane type SIBO. With the methane type, you're going to need to use one other agent in order to kill it. So there's a few different ones listed there. And generally, I'll do this course for 2 weeks, not do any other changes, no diet changes, nothing else, until I've just done this. And then I'll retest them to see if they've improved. Sometimes I have to repeat a course because their numbers are so high that I need to bring it down. But I'll recheck it, and then once they're down, then I can go into the next phase. If somebody's like, I can't afford, because that was a big problem with the Xifaxan, it's pricey. It's getting better, but it's pricey. Then people are looking for, then I'll maybe do one of the other antibiotics, and then we'll do some natural things. So again, I like more holistic, supplement, natural kind of things. So there's a list of a few that I use. The course for it is longer, just because it is natural, but they're easily available and I can use them. And obviously, depending on the type, I might pick one versus the other. Second phase is now, once I've done a treatment, is the bacteria is gone, but I still haven't done anything to correct the problem and to identify what else could be going on. So if there's low motility, I may start them on something. If they're not digesting their food, I'm going to start them on something. If they're using probiotics, which is like now we should get probiotics, no. We don't want to add more bacteria in because right now you have a problem with bacteria not getting out. So I don't want to add anything in. I like probiotics. They're great for your lower intestine, but for the upper, if you've got SIBO, you're just adding. And then I will reevaluate medications. PPIs and narcotics are the big ones. Those ones are really hard to get people off of, but they are causes for recurrent symptoms. If it's not SIBO, I also want to keep in my back of my mind that, I've tested them, I've got the data, but what else could it be? Like, do they have something that they're eating that's off? Is there medication? Is it yeast or parasites? I mean, a lot of people harbor yeast, women chronically getting yeast infections. Well, this yeast just doesn't pop out of air. Like, it's there, it's in your gut, and you're getting a yeast infection. Athlete's foot, jock itch, any of those things, you got to think yeast and you want to treat it. Any parasitic infection. And then we talked about bloating as one of the common things with abdominal pain. So let's not forget in women that women who have ovaries can have a chance of ovarian cancer. So not just like focusing just on this, but making sure we're looking at the whole woman in that case. And then inflammatory bowel disease as well. By the time they're coming to see me for SIBO and diagnosis, they've already seen GI, they've already seen their primary, so they've already had scopes done and hopefully ruled in or out, like ulcerative colitis or Crohn's or something of that sort. And then the third phase is to prevent this. We do not want this to happen again because if I don't correct their motility or their digestive enzymes, then they're going to keep having this. It's going to keep damaging their microvilli. It's going to keep putting them in nutritional deficiency. So I always want to keep thinking, how do I keep this from happening again? And so we talk about prevention. So when you want to prevent regrowth, after you've treated them with the antibiotics, then you need to put them on a special diet called the FODMAP diet. I'm going to talk about that a little bit. There's a few other different types of diets too, but this is the most common one. Continue to address the underlying symptoms, and then do any workup if you need to check for leaky gut, food sensitivities, and a microbiome balance. And microbiome truly, does control you, so you want to make sure you have a good microbiome. The FODMAP diet, FODMAP stands for fermentable oligosaccharide, disaccharide, monosaccharides, and polyols. Basically, they're just sugars. And these sugars don't do well for SIBO because the bacteria feed off of them. So people who eat certain foods that got high FODMAP scores tend to have just that uncomfortable, bloaty feeling after they eat. And it'll usually happen, within a few hours of after eating. High FODMAP foods are dairy-based foods, wheat-based products, beans and lentils, certain vegetables, and I hate this, that it's onions and garlic, because, how do you flavor anything? And then certain fruits like apples, cherries, pears, and peaches. So there's a whole list, and you can see about avoiding those. And then other things to note is that, fiber supplementation if they've got constipation, so again, keeping things moving, micronutrient support, so they're not absorbing proper vitamins because their microvilli are damaged. How am I going to get that supplementation back into them? With vitamins, if there is yeast, I'm going to treat it, and if there's medications, I'm going to reevaluate that. How long does it take to treat? It really depends on the overgrowth level. If your levels are high, it's going to take me 2 weeks of the antibiotics, another 2 weeks possibly, and then another, so it can go on and on. And if I don't address the conditions that are leading up to this happening, then it can go on for months. So it just depends on how motivated your patients are to do it. All right, sorry. I went really fast because I mean, there's a lot to say here, but I also didn't want to and I can always slow down.
Thank you very much, Tasneem. Ben, Mohammed Bhai?
So I am not a physician. So a layman thank you. As a layman and patient तरीका से अगर मैं कोई primary care physician पास जाऊँ तो वो लोग आप बता test नहीं करे because insurance नहीं आपका इतने.
No, it's not only insurance based. It's multiple things, right? So one, your primary care physician may not know about this condition.
So it's a training issue, right?
It could be a training issue, yes, right. Because this falls more into like a functional medicine.
So when does a patient, so if you want to empower patients, when does a patient think of going to a physician like you?
I mean, yeah, I feel like always.
Well, always is a very easy answer, right? But
yeah.
mean,
the thing is, so this is the thing. I do functional medicine, and I've done primary care.
Okay.
And what I tell my patients who have primary care and primary care doctors is you should still keep your primary care doctor because there's so much value in that, and they do a lot of stuff. But you should also have a functional medicine doctor on the side because no matter what you're dealing with, everybody in this room has something going on, whether it's hormone imbalance, pain, gut issues. Those are like your core things. And to see a functional medicine doctor once or twice a year just to make sure that all your labs and things are done is not a bad idea. And it can be age dependent.
So it's on top of, in addition.
In addition. It's not insurance based. So I will just tell you that. It's all it's all cash, so it's not insurance based. So that does make it a bit challenging. Most of the people look at this from I like it because I can prescribe things, I'm not bound to not prescribe things if I need to. But I love doing this because the patients who are coming to me are really motivated to get their health together. And I like that because I know that one of the things that used to frustrate me is oh my gosh, why are you not just eating well and controlling your diabetes, Why am I having to figure out what to give you on top of insulin? So it was very hard. But you're right. From a layman's perspective, if you don't know it, it's very difficult. And I think that's where the conversation, this is available. That's why conferences like this, if doctors take it back and say, there's a thing called functional medicine. If I'm stuck, I know who I can call and I can ask and I can look at other things. So not to accept that, oh, my labs are all normal. I can't tell you how many times I hear, my labs are all normal, but I feel horrible. And it's okay, so you've looked at the first tier of labs, right? Thyroid, fatigue. Thyroid is looked at all the time. How many people have thyroid? It's ridiculous how many people have thyroid. And yet the TSH is the only number checked. And there's more to it. When I do a thyroid test, I have 5 other tests I check with it. So I feel bad because you're right. As a patient, and if you don't know it, you're stuck.
My thesis is that if a patient, normally physicians who because largely it's driven by insurance. But my request to physicians is that they should ask the patient that, look, I have a separate arm. I'm not primary care physician, maybe they got a training in functional medicine, certification or something. ताकि ये लोगों ये ऑफर करी सके, ताकि एक डॉक्टर पासे जाए तो खूब wholesome care मिली जाए लोग में. That's really what I'm saying. And you can refer because you refer to other specialists as well, or they should then refer.
Yeah.
Right. I don't know how many primary cares are here. I don't know if you have data from your boards. Kitla primary care functional medicine refer kare chhe. It'd be interesting to know.
Yeah. It's hard to know. I wouldn't know, and I think a lot of it is driven by insurance. Because it's the visits are, I've got 15. If you work for a big group, I used to work at Kaiser. I had 20 minutes to deal with their 5 problems in primary care. I can't do that, and then what's the quality of what I can offer? And so I don't have time. And also at that time, I didn't have the knowledge of all these other specialty tests that I could order. So if I had that knowledge, I would have done it. So part of it is just that we're not trained to do that in medical school. Sadly, we're not trained to do nutrition in medical school, and yet we say eat well. Yeah. So I had, you can look up, I had my number and my email and everything on there, and then I know that time is limited, so they switched the slides, but you can always text me or email me or something, but yeah, I don't know where the slide is.
It's just a quick, but not really quick comment actually. So I'm Batul, I'm a pediatric gastroenterologist from Chicago. See, my thing with this is, and actually bhaiya humna kidu ke I don't think these two things should be viewed as separate entities, right? I think what is of most value in your case is that you have the experience of having been a PCP and that you're bringing that functional medicine piece to it. I think viewing the two things as mutually exclusive is the problem, right?
Yeah, you're right.
So I think what we need to revert to is not so much mara pediatrician, mara PCP nathi apidu, so I'm going to go seek something elsewhere. Because I'll tell you on the other side of things, from a specialty perspective, cases people are jumping from specialist to specialist when the underlying issue is a mental health issue.
You're right.
Right? And there's an eating disorder that's undiagnosed, or there's generalized anxiety that's undiagnosed, and they go from all types of specialists, functional, looking for that answer when the answer is already in front of them. So I think it has to be a combination of both of these things, and I would really encourage. See, one thing that I noticed from yours, again, just from my lens as being from the typical conventional medical therapy, is that for SIBO, there are gold standard 2 antibiotics that we use when SIBO is diagnosed, Flagyl and rifaximin, right? Those didn't make it to your list. Were they? Oh, okay. Maybe I just didn't see that. But I think things like that, right? Like if you're doing the Flagyl and the rifaximin in combination with all of the other things that you're doing, is really important. And we don't get that training in gastroenterology fellowship, right? And so I would encourage patients and specialists and primary care providers to not just say, okay, like, I don't have the answers, so now you go to functional medicine. It's how can we incorporate both things right from the outset?
Yeah, I mean, in an ideal world, you'd be incorporating it all the time, right? But I think your limitations are time. And so, how do you incorporate, how do you go through that mental, because you're right, there's those patients who skip from, like, they've seen every specialist twice, right? And they're looking for answers and they're not going to be satisfied, so it's hard.
There are many things that mask SIBO.
Yeah.
And SIBO is not the go-to and end-to for everything.
You're right.
In medicine or functional medicine.
You're right.
So it's of value to have the patient be seen by someone else. Yes, it's a function of time, where they spend the time with that person to try and figure out what's going on. But SIBO is not as common as it's made out to be.
No, it's not. And it was just the topic I chose.
I don't want people to go with an impression that every PCP, when they have a couple of symptoms that is describing, is SIBO, because then we're chasing the wrong thing or we're doing the wrong test.
Yeah, and that's why you're never chasing the diagnosis. That's the diagnosis, but I decided to talk about that, so that's why my topic is geared towards that. But to know.
For the room to realize that this is not as, because then an impression someone will carry that everyone has SIBO.
Yeah. Which is not the case. But, it's kind of like when you're in medical school. It's like, oh my God, I totally have fibromyalgia and chronic fatigue. Yes, it's not the to go. It's one diagnosis. It's something you can look at. You can rule in or rule out. But we talked. That's why there's a history part, right? To figure out which direction to go. And I just chose to do my talk on SIBO. So yeah, it went that way. Sorry.
Wonderful presentation. Obviously, there are a lot of questions, and so you can address more questions in the evening as well.